Hello and welcome everyone. Thank you for joining today's session on your favorite channel in understanding cancer, Cancer Reach. Cancer Reach is an initiative by our very own tumor defeater, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers access the right treatment at the right time. Today's topic is a very interesting one because cancer has progressed from broad approaches like chemotherapy to more personalized therapies. Science has been making strides to not just treat the cancer but to do so with precision and with fewer side effects. One of the most promising advances in this journey is something called as an antibody drug conjugate or ADCs. Today we'll explore how ADCs are shaping the future of cancer care. Without much further ado, let me begin by introducing our doctor to you. Dr. Krishnamani has been associated with AOI hospitals here in Hyderabad since more than a decade now. He has extensive expertise in managing a wide range of cancers, including both solid tumors and hematological malignancies. He has been actively involved in academic contributions and professional development. He is well versed in delivering advanced therapies such as ADC therapy, biological therapy, immunotherapy, and is also skilled in managing the medical emergencies that come up with managing these therapies. Hello and welcome to you, sir. Welcome to today's session.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. So we welcome you all, and today let's talk about ADCs, antibody drug conjugates.
So, sir, before I ask you what is ADC, how do they work, I just want to understand what made you choose this topic for today's session.
So let's understand that cancer treatment or cancer itself is evolving. Okay, the knowledge on cancer is evolving day by day. So when you talk about cancer and treatment, everybody thinks about chemotherapy. Now, from chemotherapy, we moved to targeted therapy. Then the era of immunotherapy came in 2014-15. Then ADCs came. ADCs started almost 10-15 years back. Now ADCs have picked up in the last 1-2 years. This is called antibody drug conjugates. So why we chose this is we want our patients or our people to know what's the latest happening in cancer and anything which is different, which is innovative, and which is useful for our patients, like how we discussed artificial intelligence in the last episode. Yeah. So ADCs today are a niche set of drugs. They represent a revolutionary treatment in oncology. They have been there in the last 5-10 years, especially the race for ADCs has picked up in the last 2-3 years. That's the reason and it is being used in a lot of diseases. It's being used in blood cancer, it is being used in lymphomas, it is being used in breast cancer. So that is the reason bladder cancer. We wanted our people to have some knowledge on what is this treatment. How is it different from chemotherapy or immunotherapy?
Okay. So, would you tell us something highlighting the development of the ADCs? Like, how were they found out or how did they develop?
So there was always in cancer people like, okay, let me give you an example. Now India and Pakistan fought a small war or a battle, whatever you say. We sent specific missiles, specific drones, and targeted specific areas like some terrorist hideouts. We didn't hit a neighborhood or a civilian locality. So that is called precision strike or surgical strike, you say. So the same concept of precision medicine or magic bullet in cancer was proposed by a physician by name Paul Ehrlich. I don't know if he's the photograph which you have put up on the slide.
Yes, sir.
Okay?
Yes, sir.
So he coined a term called magic bullet. Magic bullet, what he meant was your drug is going and killing the tumor cell, but not interfering with the normal cell. So that is precise targeted missile or treatment or targeted missile. So that is how the concept started. Then a lot of studies were done in the lab. It was done in mouse models. The first set of ADCs started in uh, leukemia. Now, what is an ADC? Antibody drug. Conjugate is a link. Antibody means it is there in us also, like immunoglobulins we have. So immunoglobulins are there in your body. There is a technology called hybridoma technology. It came in the 80s. Because of the hybridoma technology, you were able to produce antibodies outside the human body. And those antibodies are what which we use, monoclonal antibodies, rituximab, trastuzumab, okay, all these kinds of bevacizumab, etc. So antibody and drug. Drug is always there, chemotherapy. Antibodies was prepared en masse in large quantities by use of the hybridoma technology, which came in 1980. So this concept of by Paul Ehrlich, which was the magic bullet concept, because of the hybridoma technology, you were able to produce antibodies. You were able to link it to a drug, and then you are delivering it to the tumor cell. This is how it has evolved. And today you use it in leukemias, you use it in lymphomas, you use it in HER2 positive breast cancers, you use it in triple negative breast cancers, you use it in bladder cancers. Yeah, so the list is on and on and on. So there are new drugs, new deliveries, new antibodies, new tumor types. So this has been the history of the development of ADCs. So the basic reason why ADCs were conceptualized was you wanted a precision strike, a magic bullet, which will hit the tumor cell but not trouble the normal cell.
Okay. This is the concept itself, the development of the concept and the history behind it itself was very interesting to listen to, sir. So, can you tell us something about how the structure is and how does it function?
Simple. So you have an antibody, you have a drug, you have a linker. Linker is a conjugate. Antibody is this, what you have shown. This is your immunoglobulin in your body. It looks like this. Okay. It has a heavy chain and a light chain, we say. So the antibody and the drug are linked with each other because of a linker. And this is delivered to a cell. And then the drug is sent inside the cell, or the drug is taken up by the cell. So the side effects are not outside the cell. So now there are a lot of things. What is the antibody? What is the weight of the antibody? Whether the antibody can release it outside the cell or inside the cell. How is the linker? Is it able to attach to the cell? It should have a receptor, FC receptor, we say. It should attach to the cell. How well is it able to attach? How well is the drug being internalized by a part of the cell called lysosome or endosome? And then it should be released within the cell. Whether the linker is a cleavable linker or a non-cleavable. Cleavable means outside the cell itself it breaks. Non-cleavable means it is transported inside the cell and it breaks. So non-cleavable is better because cleavable means you may have some additional side effects. So this is the structure. The basic structure is an antibody, a drug or the payload, which we call, and the linker or the conjugate.
How do they work in the cancer cells?
So
How
this
do
is
they?
so you put up very beautifully, right? So look at this figure now. You have an antibody. That linker is attached to the payload, which is the red circle. Number one step is it goes and attaches to the cell. Okay, it goes and attaches. That is number one. Next, it goes inside the cell, endocytosis. It goes inside the cell. Once it goes inside the cell, number two is the degradation in the lysosome. So there is a part of the cell called a lysosome which breaks down into the antibody, into the linker, into the payload. Then the payload is released, release of the payload, and it kills. The payload goes and kills the cell. There is something called tubule, microtubule, which controls the cancer cell. So that microtubule is damaged. And finally, cell death occurs. So this is a very beautiful picture of how the antibody goes and attaches to the cell. It is internalized. The lysosome breaks everything, releases the payload. Payload goes and kills the cell by blocking the tubules. And finally, the cell is dead and the contents are released.
Okay, sir. My next question would be, do you have types for antibody drug conjugates?
Yes. So the types, as I told you, depend. The commonest type, which is the antibodies which are used, are IgG, in which IgG1 and G3 are common. Because what you should understand is the weight of the antibody is important. How well it attaches to the antigen is important. Okay, the linker is important, whether it is cleavable or non-cleavable. The payload is important. The pH, whether the environment around the cell is acidic or alkaline, is important. Are there any enzymes called proteases outside the cell? That is important because if you have proteases outside itself, the ADC is broken. So this is how you divide the ADCs based on the, and finally on the FC receptor, how well are the receptors concentrated on the cell. So the tumor cell receptor status, the antibody weight, the environment, proteasomes, pH, again environment, linker stability, payload, and whether it's a cleavable or a non-cleavable linker.
So, do we have any ADCs which are currently like available in the market? Just to name a few for the general public's information.
In breast cancer, we use a drug called TDM1, trastuzumab emtansine. That's an ADC. It's a non-cleavable linker, non-cleavable ADC. The next one, TDXD NHER2, we call trastuzumab deruxtecan. That's an ADC. We have brentuximab vedotin in lymphomas. That's an ADC. We have gemtuzumab ozogomycin. That's an ADC in leukemia. We have sacituzumab govitecan. This is in triple negative breast cancer. Enfortumab vedotin in bladder cancer. All different names and very difficult to pronounce. Okay, these are all used and used very well.
Okay, sir. Now, so when you talk about giving the drug to the patient, how do you select the patient? Is there a specific eligibility criteria which the patient needs to fit into in order to get these ADCs?
So all these drugs are approved by guidelines, international guidelines after randomized trials. Now take each drug. There is a clear-cut definition where you have to use. TDM1 HER2 positive breast cancer, metastatic setting, after progression of trastuzumab. TDXT HER2 positive breast cancer, after progression of trastuzumab. TDM1, which I told you in the beginning, can also be used in the adjuvant setting if you don't get a response to trastuzumab. So patient selection is based on very strict criteria, and this is as part of guidelines. It is either used in the late stage or early stage, whether you are HER2 or triple negative, depending on that.
What would be the costing for each of the drugs, sir? Like a general costing, because I believe in India, cost is a major factor which decides whether the patient will be able to take that medicine or no. So, what would be the general costing for it? Just a general range.
Yeah, unfortunately, it is still very overpriced or they are very highly priced. TDM1, which was the earliest ADCs which came in the market, is available as low as 60,000 per cycle now because you have a generic TDM1. But other ADCs are still patented. They don't have generics. So the cost goes in lakhs, between 2 to 3 lakhs per cycle. And if the medicine is working, you don't have a fixed number of cycles. You keep continuing the drug. So most people cannot afford because they are definitely expensive.
So, what would be some of the common side effects which are associated with all of these ADCs?
So they can cause weakness, nausea, vomiting, liver enzyme problems, and all that. Some important side effects, for example, NHER2, TDXD, interstitial lung disease. It can damage your lung. If your lung is damaged, you have to stop the drug. Okay, so these drugs sometimes can cause some, what do you say, different kind of side effects, which are not very, which you don't see with your regular chemotherapies and all that. So ILD is extremely common TDXD, and you should be wary of. Otherwise, your regular set of side effects. Platelets can go down with TDM1, weakness, nausea, liver function abnormalities, muscle problems, etc.
When you compare the side effect profile with the chemotherapeutic drugs which are available, is it more manageable with the ADCs?
Correct. It is definitely. Chemotherapy is a very generalized kind of a treatment. ADCs are very specific. So side effect wise, yes, if you ADCs are much more manageable. But once you develop ILD kind of problems, you have to stop the drug
So they are safer to use as compared to the chemotherapy drugs.
because of their different mechanism of action.
Okay, sir. So what would be the future for antibody drug conjugates? Like how is it advancing in cancer treatment?
ADCs are being combined with immunotherapy in trials. ADCs are being combined with small molecular inhibitors, we call. So ADCs, they are trying with different payloads. Okay. They are also trying to reduce the effect on the lung and all that by tinkering with the structure of ADCs. And they're also using this drug in different tumor types. For that to use, you have to find out what antigens will be specific for the ADC. If you will not believe, there are close to 100 trials on ADC going on at any time in the world today. So that is the level of advancement going on.
So, sir, I'm going to ask you to bust a few myths now. So the first one is ADCs are only for advanced cancers.
No, we, as I told you, TDM1 is given after surgery in HER2 positive breast cancer if you don't get a pathological response. So it is used in early cancer also.
Okay. So early and advanced cancers both.
Correct.
ADCs are another type of chemotherapy.
No, chemos are different. They attack normal and cancer cells. ADCs are completely different. Their mechanism we discussed is different. They are magic bullets, as you call, or precision targeted treatments.
Okay. All cancers can be treated with antibody drug conjugates.
Not yet.
Sir,
Breast, bladder, lymphomas are being treated right now. It'll take some time, maybe.
okay. So the last one is that ADCs can replace surgery and radiation in cancer therapy.
No, no, no. We should not see. I'm embrace technology or a new advancement, but don't disregard the established rules of treatment. Surgery, radiation, they're all important for cure for our cancer patients. So our patients should not think that I take ADC, I'll not get surgery done. No, your doctor will tell you where you need surgery, when you need surgery, where and when you need radiation. And same way about ADC also. One doesn't replace the other.
Okay, sir. So any parting message for today's audience on this interesting topic?
So ADCs are one in of the future in oncology. Let's understand that. The future of oncology is very bright. There are a lot of treatments coming up. ADC forms a main part of the treatment. There are a lot of trials going on. They are already being, we are using ADCs in breast cancer, as I told you, in lymphomas and bladder cancers. And it's a very precise targeted medicine so that the side effects are minimal and the tumor cell only is damaged. So it's interesting time. Yes, the costs are high, but Indian companies are coming up in generics and the cost will come low so that our patients are benefited and they're already part of guidelines. So there'll be more indications for ADCs in the future.
Okay, sir. Thank you for taking time out for this interesting session today. And I hope to see you again next Friday, sir, with another interesting topic. Thank you,
Thanks.
sir.
Thanks so much. Thank you.